Okay, welcome to the GTI webinar. I'm Dr. John Stone. I'm a professor of medicine at Harvard Medical School and the Edward A. Fox Chair in Medicine at the Massachusetts General Hospital. Delighted to have you here today. We have a nice mix of people from academia and industry. So let's get going. First, let me say, as you know, every once in a while, there's a little glitch with technology in this world of Zoom. If there is some sort of glitch and we have to ditch today's webinar, we will send you a recording of this. So never fear if that happens. Hopefully nothing will happen. So I want to start with some disclosures. I led the groups that developed the GTI and the pediatric version of the GTI, the PGTI. And I've done consulting with a number of companies that use these instruments in trials. These are listed here, but this is not a sponsored talk. This is a passion of mine, not a talk sponsored by industry or anyone else. So this is what we're going to do. I'm going to share with you data from a phase 3 clinical trial that recently published GTI data. And I'm going to spend some time before showing you a demo of the GTI app. I'm going to show you what those GTI scores tell us. And we'll spend a few minutes demoing the GTI app, and then we can take questions from the chat. Actually, not from the chat. Please write your questions in the Q&A. Okay, so this was the paper published in the New England Journal of Medicine 3 weeks or so ago, Avacopan for the treatment of ANCA-associated vasculitis. Avacopan is a complement inhibitor. This was a randomized double-blind placebo-controlled trial. And this was the design. Let me just share that with you briefly. So the new treatment group, the Avacopan group, received Avacopan, 30 milligrams twice a day, in addition to standard care, either rituximab or cyclophosphamide, followed by azathioprine, and a dummy prednisone taper. So in theory, patients in the Avacopan group did not receive any steroids. They were compared to the prednisone group, which received an Avacopan placebo plus standard of care, either rituximab or cyclophosphamide, followed by azathioprine, and a real prednisone taper that started at about 60 milligrams a day and was tapered to 0 over 20 weeks. Now, the data that I'm going to show you today related to the GTI pertain to the 26-week primary endpoint, an endpoint at which the GTI was measured, and also the 13-week time point at which the GTI was measured. The investigators used the GTI at both of these intervals, 13 weeks and 26 weeks. So this slide, this graph shows the amount of prednisone or prednisone equivalents that the two groups received. The gray group here is the prednisone group, the comparison group, and you can see they received more prednisone than the Avacopan group did. The Avacopan group did receive some prednisone, and that's shown here in the maroon line. So over the course of the trial, over the full 52 weeks, the Avacopan group received about 2/3 less prednisone than the comparison group, than the prednisone group. And that's shown in this table here, which is from the supplement to the New England Journal of Medicine. This table shows the 52-week cumulative prednisone dosing. And you can see that the prednisone group received about 3 times more prednisone equivalents than did the Avacopan group. This is 52-week, not 26-week or 13-week data about prednisone. But over the course of 52 weeks of follow-up, patients in the prednisone group received a mean of about 12 milligrams of prednisone a day compared to about 4 in the Avacopan group. So the Avacopan group received about 3 times less. Now, when we're looking at an instrument designed to differentiate with regard to steroid toxicity, 2 groups, it would be nice if one group received prednisone and the other did not. There was but as I've just shown you, some patients in the avacopan group received prednisone as well. So with regard to the primary efficacy endpoint in the trial at 26 weeks, the two groups were non-inferior to each other. Both the avacopan and the comparison group, about 70% of patients in both groups achieved the primary endpoint of disease remission at 26 weeks. But what about the secondary endpoint? So table 2 in the New England Journal of Medicine paper shows the key secondary endpoint, which was the GTI. And this is what I want to spend some time explaining to you today. The cumulative worsening score and the aggregate improvement score, two components of the GTI, are shown here in table 2. And over here in this red square, it compares the avacopan group to the prednisone group, and these negative scores indicate that the avacopan group had lower GTI scores compared to the prednisone group. So let me explain just what that is telling us. So the GTI is a standardized weighted instrument that measures change in steroid toxicity. The GTI gives you two scores plus a catalog of damage. The two scores that the GTI provides are a cumulative worsening score, or CWS, and an aggregate improvement score, or AIS. These scores reflect steroid toxicities that would be anticipated to change over the course of a clinical trial. They would increase if there is more steroid used and decrease if there is less steroid, fewer milligrams of prednisone used. And then the catalog of damage, which is not scored and not weighted, is called the specific list. This includes things such as osteonecrosis and bone fracture, which are damage. They may reflect prednisone use, glucocorticoid use before trial entry. So items in the specific list are not scored or weighted. But the two scores that we're going to spend more time talking about now are the CWS and the AIS, the cumulative worsening score and the aggregate improvement score. So the CWS and the AIS data are derived from 9 domains of steroid toxicity. These domains are important to patients, they are important to clinicians, and again, they reflect the steroid toxicities that would be expected to change over the course of a clinical trial, 3 months, 6 months, a year, or even longer. These domains of steroid toxicity are the body mass index, weight gain is very important to patients, blood pressure, glucose as measured by the hemoglobin A1C, lipid metabolism as measured by the LDL, steroid myopathy, this is measured by the investigator. I should say that these 4, the first domains that I mentioned, are typically, they can be measured very easily by the clinical trial coordinator. But the remainder need to be measured by the clinician investigator, the physician, typically. So these are steroid myopathy, skin toxicity, acne, hirsutism, etc., neuropsychiatric effects, insomnia, depression, and infection, of course, a very important part of any clinical trial. And I will say that these data are typically collected in the course of a routine clinical trial. What the GTI has done is figured out a way to add these up in a way that sums to total steroid toxicity scores. There's one final domain that was not used in this trial, and that's the bone mineral density. This was not used as part of the GTI in this trial, but can be. So each of these domains that I just mentioned is weighted. The items within each domain are weighted. So for example, looking at the BMI domain, if the patient's weight decreases by more than 5 BMI units, then the GTI scores that as a -36. If the BMI decreases by between 2 and 5 units, then that is scored a -21. If there is no significant change in the BMI, that's a 0 weight. And if the patient gains weight, then that is associated with a correspondingly positive increase in the GTI scores, the CWS or the AIS. The approach to developing these weights was outlined in JACI in Clinical Practice, which was published just in January of this year. One other domain that I'll show you is the glucose tolerance domain. Again, it's measured according to the hemoglobin A1C, but medications for glucose metabolism also count in GTI scoring. So if the patient has to start insulin, that counts as a steroid toxicity. In this case, there's been an improvement in hemoglobin A1C and a decrease in the medication. This is equal to minus 44 points in the aggregate improvement score. If there's no significant change in the glucose metabolism, that's 0 points. And if there is an increase in the hemoglobin A1C, possibly associated by an increase in medications, then that is associated with positive weights, either 32 or 44, depending on whether there is an increase in medication or not. So the cumulative worsening score, as its name implies, is a running total of steroid toxicity. It captures both permanent and transient steroid-related toxicities. Some toxicities may be caused by prednisone, but may resolve. And the cumulative worsening score keeps those on the board, even if they go away. So the CWS is a running total of steroid toxicity. If the new treatment decreases steroid toxicity, then the CWS will be lower in the new treatment group than it is compared to the standard care group. Now, the AIS, the aggregate improvement score, takes advantage of the fact that many patients have steroid toxicity at baseline for immune-mediated diseases, which unfortunately we seldom cure still. Many of these patients have been on prednisone already by the time they come to a clinical trial. And one of the things we want to be able to show about a new drug is that it actually facilitates the resolution of baseline steroid toxicity. So with regard to the AIS, which is calculated on the same data used to calculate the CWS, but with the aggregate improvement score, if a toxicity resolves, it is removed from the score. So the AIS confirms that a new drug reduces baseline toxicity over time in one group of patients compared to the other. And if a new treatment decreases steroid toxicity, then the AIS will decrease or maybe even become a negative number. So these were the GTI scores depicted in graphical form from the avacopan trial that was just published. The prednisone groups are shown in gray here, the avacopan group in maroon. These are the 13-week and the 26-week measurements of the GTI, specifically the CWS. And you can see that the CWS is higher in the prednisone-only treatment groups, lower in the avacopan groups. These comparisons are statistically significant, as indicated by the star here. So at only 13 weeks and at 26 weeks, both very fast, but the GTI already demonstrated a difference in steroid toxicity between the avacopan and the prednisone groups. That's pretty quick, particularly considering the fact that the avacopan group received some prednisone as well. Now, if we look at the aggregate improvement scores shown here on the right, they are lower than the CWS scores, and the avacopan group has far lower AIS scores compared to the prednisone-only treatment groups at both 13 weeks and at 26 weeks. And again, these comparisons are statistically significant. So this is a summary of the 26-week result. With regard to the primary efficacy result, as I've indicated, these two treatments were non-inferior, and the p-value for non-inferiority was quite significant. But if we look at the GTI, CWS, and AIS scores, the avacopan group was far superior statistically to the prednisone-only treatment group. Now, is that clinically significant? So the minimum clinically important difference for the GTI scores, or MCID, is estimated to be 10 points. And the approach to deriving the MCID is described in this paper here. It's beyond the scope of our webinar today, so I won't go into that. But 10 points is the MCID for the GTI. So back to table 2. What do these scores tell us comparing the avacopan group to the prednisone group? Well, the numbers are more than 10 points lower in the avacopan group, both at 13 weeks and at 26 weeks here. So this table shows that avacopan reduced steroid toxicity compared to prednisone only, the prednisone only group, in a way that was statistically significant, but also clinically significant, both statistically and clinically significant. And the GTI permitted them to make that claim. So the avacopan exceeded the GTI MCID at both 13 and 26 weeks. So let's pause that now, and we're going to see the GTI app in action before we cut over to that. This is the face of a 20-year-old man with ANCA-associated vasculitis. He was not in the avacopan trial. He is a patient of mine, and you can see the steroid toxicity reflected in his face. Moon-like facies, acne, hirsutism. When he started his prednisone at the age of 18, when he was a high school senior, he weighed 150 pounds. By the time I met him, he weighed 225 pounds. So we'll switch over now to the GTI app, and we'll show you the app in action. Okay, so this is the app, and this shows visit 1, GTI visit 1, and GTI visit 2, and GTI visit 3. What we have done is we've entered the patient's baseline data. So the GTI calculates change in steroid toxicity. We're going to show you the change in steroid toxicity between baseline and the V2 visit, the second visit, and then between the V2 visit and the V3 visit. We've already entered the baseline data. So let's enter the data for the first follow-up visit. Say, hypothetically, this is 13 weeks. This is the main screen, the home page, if you will, of the GTI app. And it is arranged according to a logical flow in a clinical trial visit for a patient. So the first thing that happens in a clinical trial visit is the coordinator will update the patient's medications. The patient's baseline medications were already entered. The patient was on insulin. You can see over on the lower left at baseline. Now at the first follow-up visit, the patient is off insulin. His glucose metabolism has improved very nicely. In addition, his lisinopril, which was 20 milligrams at baseline, is now 10. So he has had improvements in both of his medications to treat glucose metabolism and to treat blood pressure. And now we confirm that the intention was to decrease both of those. Then we go to vital signs. The vital signs from entry are shown on the left. The patient was 1.64 meters tall at entry and weighed 96 kilograms. The BMI calculated automatically by the app shows that his BMI was 36.7. Now at follow-up, his height has not changed, but his weight has improved substantially. He's now down to 89.1 kilograms. And the app calculates the BMI automatically. His blood pressure has also improved, going from 144 at baseline to 132 over 85 at follow-up. The items of the specific list, which are damage, are sprinkled in a domain-specific way. So you'll see these come up as we go through, which is a logical flow for the investigator. But there were no specific list items related to blood pressure. So this is now complete, and we go to labs. So again, the patient's labs from baseline, hemoglobin A1C of 6.3%. There's been a significant improvement. The hemoglobin A1C is now down to 5.5%, despite the fact that the patient has been able to stop his insulin. His LDL value, which is in European units, if you will, in millimoles per liter rather than milligrams per deciliter. His LDL hasn't changed very much. It's 3.1 now in follow-up. So the LDL is now complete. Bone mineral density, although the avacopan trial did not use bone mineral density, we've included it in this demo, since bone mineral density is a very sensitive indicator of prednisone. So we'll say, for argument's sake here, that the patient's bone mineral density has not changed. Essentially, the bone mineral density is 5.1 grams per centimeter squared at the femoral neck, and 5.0 at the lumbosacral spine. Okay, and there have been no specific list items occurring. Now the clinical research coordinator might put the patient into a room. The research coordinator has finished with what he or she needs to do with the patient, checking medicines, vital signs, weighing the patient, etc. Patient goes into an examining room where the clinical investigator examines the patient for myopathy, for skin changes, for neuropsychiatric toxicity, and for infections. So the patient did have myopathy at baseline, but now it has resolved. So up in the upper left, you see that he had a minor steroid myopathy at baseline. The app cues the investigator into what these definitions are, reminds the investigator of the definition. So rather than having to find some dusty manual of operations on a bookshelf somewhere, all of the use materials are contained within the app. Okay, next slide. And now we move to skin effects. So the patient had lots of skin effects at baseline. In the upper left, you see that there was moderate hirsutism, there was a minor acneiform rash, and there were striae that were moderate. There are skin effects now at follow-up at 13 weeks, but we'll say that the hirsutism has improved. It is now only minor. And the definitions, again, of each of these grades is included in the app to facilitate rigor and consistency in scoring. You can blow up some of these images here to see what minor hirsutism is. And the patient's acne has actually resolved at this point. And the striae remain moderate. Okay, then we move to the neuropsychiatric domain, and the patient had these manifestations of steroid toxicity at baseline in the neuropsychiatric domain. There was moderate insomnia and moderate depression. Both of these are now minor at follow-up, at the first follow-up visit, because we're going to go through the second follow-up visit as well. Again, the definitions of these neuropsychiatric toxicities are included. And then we go to infections. And the patient had oral candidiasis at baseline and has had one episode of oral candidiasis again between baseline and week 13. And so that completes the changeable elements of the GTI. And now we round out the list of other toxicities by looking at the specific list. And we'll just say that there have been no additional toxicities, but it shows that the patient had a cataract at baseline, and that was carried forward now to this follow-up visit because items in the specific list represent damage, they don't change. Okay, so now we're complete and we can get the first GTI score. We can get the score between the change in steroid toxicity between the baseline visit and the first follow-up visit. Over on the left-hand side, you see the individual domain scores. And then in the upper right, you see the cumulative worsening score and the aggregated improvement score. And what this demonstrates is that there has been a little bit of worsening. The patient did have an episode of oral candidiasis between baseline and week 13, but all in all, there was substantial improvement in steroid toxicity. So the AIS had actually improved by minus 209 points. Okay, why don't we just run through this quickly and we'll enter one more visit. The PGTI is very, very similar to the GTI. The one important difference is that there is an additional domain in the PGTI, and that is growth, because kids have to grow over time. They're supposed to grow over time. There is an additional domain within the PGTI accounting for growth. And it turns out that measuring stereotoxicity in kids is a bit more complicated than it is in adults because of that element of growth, which is supposed to happen. And a number of these domains have to be adjusted for the anticipated growth. The app score reduces that complexity wonderfully so that all that the pediatric investigator needs to do is enter the data. Let's put the next visit in for the adult GTI app. Here we're on visit 3 now. This is maybe week 26 or 6 months after the baseline visit. And we'll say there has been no change in the patient's medications at this time. So the insulin remains off, and the lisinopril is still 10 milligrams a day. And we confirm the clinician's intent, which is not to change the medications. And that's now complete. We look at vital signs, and both the data from trial entry and at the previous visit are shown here. Now we'll say that the weight is 90.2 kilograms, up just a little bit. The blood pressure, however, has continued to go down. It's now 132/84. The labs now at follow-up, the hemoglobin A1C is 5.4%, and the LDL was up a little bit to 3.3. The bone mineral density has not significantly changed here, 5.2 and 5.2 at both sites measured by the DEXA. There has been fortunately no osteonecrosis. The patient's steroid myopathy has remained gone, so his muscle strength is normal now. And with regard to skin effects, the hirsutism, which was minor at the last visit, has resolved, and the atrophy stria remain minor. The neuropsychiatric effects, the insomnia is now gone, but there remains an element of minor depression as well, and the definition is shown there. There have also been no infections between week 13 and week 26. And now we just scroll down the other toxicity to complete and make sure that has not been other elements of steroid toxicity that would be recorded in the specific list. They're not. And we can go now to the GTI score. And this sums the entire score since baseline. So the cumulative worsening score, because of that infection, because of that oral candidiasis that occurred in the first GTI interval between baseline and 13 weeks, that is reflected in the 19 points. But the patient has continued to have improvement in overall steroid toxicity, and the aggregate improvement score is now minus 257. Remember that the MCID for the GTI is 10 points. So this is a very nice improvement overall in steroid toxicity. Okay, so this completes the demonstration. And this represents schematically the clinical trial database, which is housed in the CRO for the clinical trial. Maybe it's within the company or at the site leading the center, but this is the clinical trial database schematically. At the site, at any of the 60 clinical sites involved in the trial, the clinical research coordinator would enter data related to medications, vital signs, labs, and bone mineral density, as I just indicated. And that would go right into the clinical trial database. The physician investigator would enter data related to steroid myopathy, skin effects, neuropsychiatric effects, etc. This goes right into the database. The GTI, which is connected to the clinical trial database via APIs, can pull data from the database, calculate the GTI, and then send that back to the clinical trials database. And the database then is able to output the cumulative worsening score and the aggregate improvement score. Now, the app is ready to use now, even without these API connections, but these can be used to really facilitate use of the app in the clinical trial, to integrate the app seamlessly with the CRO's database. It eliminates data redundancy. The clinical trial coordinator and the investigator only have to enter data related to the blood pressure, for example, once. And the APIs allow smooth integration of these data across the trial. And that, let me just show you what happened to this patient after we finally found a good steroid-sparing treatment for him. This is a couple of years later when he was down to almost no prednisone a day. He's a pretty happy guy, a pretty extraordinary change in his facial appearance.